First of all, I'd like to thank the organizers for giving me an opportunity to come to this lovely city. And I bring you greetings from the Pakistan Society of Anesthesiology from Pakistan. I must admit that you are far ahead of us, and you've got an association of obstetric anesthesia. We, the rest of us in other SAARC countries, we are still doing a bit of everything. And I don't claim to be an expert in obstetrics. As you know, my primary interests are other specialties as well. And I'm also thankful to the organizers for giving me a very practical topic. Okay. Now, coming back to failed spinal for an emergency C-section. Now, spinal anesthesia, Spinal anesthesia is now the predominant method of anesthesia for C-section, and single shot spinal with local anesthetic alone or local anesthetic combined with a narcotic is usually done. 85% of cesarean sections done in an emergency should be done under spinal anesthesia. Now, what is the failure of spinal technique? We need to know that before we go into the details. Spinal as is attempted, but no block results, or spinal is attempted, a block results, but it is inadequate in extent, quality, or duration. There are other definitions available as well, like, for example, conversion to general anesthesia, which can be considered as a total failure of spinal, or conversion to any different form of anesthesia, and partial failure is also defined as pain during surgery. Failure results in pain and inconvenience for the patient, embarrassment for the anesthetist, and potential for legal damages. Intraoperative discomfort during spinal anesthesia for cesarean section is one of the most commonly cited cause of litigation in obstetric anesthesia. And just to let you know, the two cases that went up for litigation in my country, both were from obstetric anesthesia. In one of the cases, the anesthetist had to settle out of court and he had to pay 1 crore rupees, which is nearly 10 million rupees in our currency. Now, single shot spinal in emergency C-section. What is the best practice? Because we need to know that it should be the adequate block should be established in about 10 to 20 minutes, and we need to benchmark the time. We need to benchmark the standards for dose and the concentration of the local anesthetic. Both plain bupivacaine and hyperbaric bupivacaine is used, 0.5%. And this data is from Europe, but in our countries, I think women are shorter stratured, they are thinner, so there is a variation of dose that is used. But from Western countries, the dose is 2.5 mils, which is considered a mid-range dose for most females. And this publication in Anesthesia, they add diamorphine 0.25 to 0.3 milligrams for supplementation, and or 25 micrograms of fentanyl for intraoperative supplementation. What is the role of experience in technique failure? Experienced anesthetist has been defined as one who has performed more than 100 blocks. And the benchmark for rescue general anesthesia for those with experience is less than 1%, reported as less than 1%, and those who are considered as experts, it's been reported as less than 0.5%. Now let's look at the incidence of failure of spinal anesthesia. These figures are from general anesthesia, not from obstetric anesthesia, and as you can see, the incidence varies whether the studies are prospective or retrospective. And prospective studies, again, variation, 3.1% in one study, 4% in another, whereas retrospective studies, the incidence has been reported as much higher, in some even up to 17%. What is the incidence of failure in obstetrics then? In general, anesthesia, as said, less than 1% to 17%. In obstetrics, the Royal College of Anaesthetists from UK, they give a benchmark of conversion rate to general anesthesia of less than 1% for elective cesarean sections and less than 3% for non-elective cesarean sections. Now, this slide is from a study by Kinsella. This was published in Anesthesia 2008. This is a study of 5,080 cesarean section, and he gave a rate of 6%, but this is not just for spinal, for other regional techniques as well. 94% of these patients had spinal, but inadequate anesthesia pre-delivery was seen in 29 patients, and inadequate anesthesia post-delivery was seen in 90 patients. The other important thing that they found was that the rate of general anesthesia conversion from spinal was 8% in category 1 C-section and 0.5% in category 4, where there was no urgency. So there is a difference in urgency as well. Now, how much time should elapse before diagnosing complete failure? 5, 10, 15, 20 minutes. According to Cochrane Database Systematic Review, there is a broad agreement on 15 minutes. Now, coming back to failed spinal in emergency C-section, there are a couple of unanswered questions that we need to know: whether the failure was complete or was it partial, what was the level of emergency, and has the surgery started? So we don't have that information. Now let's take the failure to place. Though in this particular scenario where you've already given a spinal anesthetic, these factors will not count, but I'm just going to go through them for the sake of completion. Now, technical failure can be due to patient's position. Ideal position, well, obstetric anesthetists do their spinals in both positions, sitting position and lateral position. Did the patient move during injection? Was there assistance available during the positioning? These can all affect the success of the spinal. Also, we heard one of the speakers yesterday on use of ultrasound in locating the spines, and if I remember correctly, 50% of the anesthetists were not in the correct position when they thought they were in L3-4 position. And some of them were above it and some of them were below it. Then there can be difficulty in needle insertion and in identification of space and needle insertion. Usually for cesarean section, the site that is chosen is the L3-4 interspace. Majority use the midline approach, but if that is unsuccessful, some people go for the lateral and the paramedian one. And again, it depends on the familiarity of the anesthetist, how familiar they are with the other techniques if they have to use it. And generally, the needle may be inadequate length, or the needle may bend during insertion. How do we know that the needle has reached the subarachnoid space? Most of us rely on appearance of fluid at the needle hub. And sometimes this may be a false sign due to the presence of cysts, arachnoid cysts, which may be uncommunicating with the subarachnoid space. So failure to place local anesthetic in the subarachnoid block can be due to landmark difficulty, spinal needle inadequate length, or a flexible needle. Now, coming to other techniques, the technique failure can be due to several reasons. It can be due to injection errors, inadequate spread of the local anesthetic, ineffective drug action, and failure of subsequent management. And we'll just go through these in a little bit more detail. The errors in dose selection, these usually have less effect on the extent of the block, but more effect on the quality of the block and the duration of the block. If a smaller dose is used, then one has to remember that some injected is lost in the hub of the needle, and consequences of other problems, if added, will be exaggerated. Injection failure. Injection failure is more of an issue with pencil point needles compared to Quincke needles, and this is because the opening is proximal to the tip and it's longer than the bevel. So some of the local anesthetic may be lost outside the subarachnoid place if your needle is not absolutely in the subarachnoid space. Leakage of solution from Luer lock connection can occur. And yesterday, again, somebody was talking about that in UK they're going to change the needles and remove the Luer lock connection now from next year. Inadequate spread. There are many factors which govern the intrathecal spread. And these factors are all listed here, which are the physical characteristics of the solution, the gravity, anatomical factors which may affect the spread, and there are several of them, like kyphoscoliosis, ligaments within the theca. There are various anatomical studies have now confirmed that there are trabeculae in the subarachnoid space, which may affect the spread of the block. Then spinal stenosis, previous surgery, previous intrathecal chemotherapy, extradural cysts, abnormally large spinal canal, or dural ectasia. Then solution density. It's important for the anesthetist to have a knowledge of the veracity of the solution and the knowledge of the vertebral curves. Drug failure. Drug failure can occur due to identification errors, and use of wrong drug from the trolley has been reported. And the recommendation is to have a minimum number of syringes present on the trolley when you're doing a spinal. Loss of potency due to prolonged storage, another problem in our part of the world because of the weather changes that occur. Refrigeration may not be very reliable, so that's also a problem. Chemical incompatibility. Mixing of solutions. The drug can be added with opioids or with vasoconstrictors. Yesterday, again, there was mention of use of neostigmine, use of clonidine. So there are many drugs that are potentially that can be added to the local anesthetic. What's the effect of those drugs on the pH of the solution and on the ionized fraction? There's still lots of work to be done on this. And remember that ionized fraction is the one that diffuses in the nerves. This interesting paper published in 2009, what they did was they analyzed the CSF in 20 patients where a subarachnoid injection with local anesthetic was performed, the block failed, and a second injection was planned after 15 to 45 minutes. And the adequate concentration was taken as 73 micrograms per mil. In 12 out of those 20 patients, the serum concentration was adequate, and they suspected that the ineffective block was due to maldistribution. And they warned that in such cases, if a second injection is done, then the concern of neurotoxicity is present. There are other rare causes like local anesthetic resistance. The mutation of sodium channels has been suspected in patients. Then glycosylation of nerve roots, for example, in diabetic patients, and tissue acidosis. What role these have to play, it's not absolutely clear, but because the reports are mostly anecdotal. Then visceral discomfort can be perceived by the patient as spinal failure. This is, as you know, due to exteriorization of the uterus and traction of the abdominal viscera. Failure of subsequent management. If one has not tested the block properly, inadequate testing can mask a partial block and can lead to problems later. Okay? So sensory blocks specifically should be tested, and also the surgical incision site should be tested before proceeding for spinal. Now, coming to the management, if no block results, then it's probably the cause is the wrong solution has been injected or drug deposited in the wrong place. And how to manage it? Repeat the procedure for category 2 if you have sufficient time, or general anesthesia for a category 1 cesarean section, that is if the condition is life-threatening to the mother or the fetus. If there is a good block but inadequate spread and the incision has not been made, if time for injection is less than 10 minutes, if a hyperbaric solution has been used, then generally the recommendation is to flex the hips and knees and tilt the table head down, which may not be possible in obstetrics. But in obstetrics, the recommendation is to turn the patient lateral, slightly head down, and then you keep her in this position for 2 to 3 minutes, and then reverse the side after 2 to 3 minutes. If there is plain solution, then sit the patient up, and cuffing may help. And if the situation allows and you're suspecting slower onset, then you wait a few more minutes. And if you have time, depending on the indication, then spinal can be repeated. If incision has been made and it's an emergency, then what options are available? One can supplement with intravenous analgesics, supplementation with inhalational anesthetics, infiltration of the wound by the surgeon, or the other option is general anesthesia. If one has not started, but it's a unilateral block, then again the cause can be positioning, or longitudinal ligaments have prevented spread. A recommendation is that if it's a hyperbaric solution, you turn the patients towards the unblocked side, wait 3 to 5 minutes. If it's an isobaric solution, turn the patient towards the blocked side. If it's a patchy block, the causes we've discussed: local anesthetic dose inadequate, local anesthetic partially misplaced, poor distribution of local anesthetic, and the management is again either systemic supplementation, repeat block, infiltration of wound with local anesthetic put in by the surgeon, or general anesthesia. Inadequate duration. Kinsella, in the audit that I previously showed you, gives the duration. The block is more likely to fail if the duration of cesarean section is more than 90 minutes. Then, if surgery is lasting longer, IV or inhalational supplementation, general anesthesia, or ask the surgeon to infiltrate. The same is true if inadequate dose of local anesthetic was delivered to the CSF. Now, issues with repeat block. Repeat block, several issues. The question would be whether the same dose of local anesthetic should be repeated or a smaller dose. It is recommended that a smaller dose be used, especially if it's a patchy block. Full dose should only be used if the block is an absolute failure. The reason they give is that some local anesthetic drug will still be present in the subarachnoid space in case of a patchy block. And this can lead to excessive spread of local anesthetic. There is also risk of direct needle trauma because adjacent nerve tissue may be already affected by the local anesthetic, and risk of neurotoxicity due to overdose. If you're giving general anesthesia for an unsuccessful regional, the recommendation is to use general anesthesia early rather than late, and hypotension is more likely in the presence of a partially effective spinal compared to where there is complete failure of the spinal. Follow-up of the case is very important. One should document. One should give an apology to the patient, especially if it results in pain, or an explanation, good explanation to the patient. And if there are successively a couple of cases that have failed, then investigation is important. So in summary, successful spinal anesthesia requires deposition of the right drug in the right place in the right dose, provided the CSF is in free continuity with the spinal cord and cauda equina, and there are no physiological, biochemical, or mechanical factors to prevent the normal action of the drug. Thank you very much.